Should be live. Hello, everybody. Welcome. Hope you're having a wonderful middle of your week here. Happy Wednesday. Thanks for joining us. Today, we're going to be focusing on early stage treatment options. So we're very excited to be offering this. Before we start, I would just like to give a quick thank you to our corporate partners and our individual donors. Thank you so much. Without you, we certainly couldn't put these programs on. So we really appreciate your support. So tonight we have two wonderful speakers with us tonight. We have Dr. Steve Horowitz with Memorial Sloan Kettering. Dr. Horowitz is a medical oncologist and his clinical expertise focuses on T-cell lymphomas, cutaneous skin lymphomas, and other non-Hodgkin and Hodgkin lymphomas. Hi, Dr. Horowitz. Thanks for being here tonight.
Thank you, Hillary. My pleasure.
We also have Dr. Sarah Noor, also with Memorial Sloan Kettering. Dr. Noor is a dermatologist and her expertise focuses on cutaneous T and B cell lymphomas and the dermatologic side effects of cancer treatment. Thanks so much for being here, Dr. Noor.
Thank you for having me.
Yes. So I'm going to turn things over to our expert panel here, and we're just going to do sort of an open discussion. And if you have any questions while they're speaking, please go ahead and submit those at the bottom of your screen to the Q&A function, and we will answer questions at the end as time allows. So I'm going to stop sharing my screen and turn it over to the two of you.
Thank you.
Thanks, guys.
Yeah, no, we're really happy to join you all tonight. We're happy that you could turn in. Happy Veterans Day. Dr. Noor and I work together at Memorial Sloan Kettering, where we have what we call multidisciplinary cutaneous lymphoma clinic. So often we'll see patients together. And we, as part of a larger team, there's another oncologist, Dr. Allison Moskowitz, another dermatologist, Dr. Pat Miskowski, and then we have radiation oncologist, dermatopathologist, but we all work together really because the cutaneous lymphomas are kind of illnesses that really lend themselves to differences of different expertises being important at different times in people's course. Because we're going to mostly focus on early stage disease, we thought this would be a good thing to have both of us here and sort of have some of the conversations that we have weekly when we see patients together. And I'll turn it over to Dr. Noor to talk about, I think, a little background, and then we'll go through some of the topics, and then hopefully have a lot of time for questions. Thank you.
So I'm just going to be sharing my screen here and pull up our PowerPoint. Okay, so as Dr. Horowitz mentioned, we will be talking today more on early stage mycosis fungoides with sort of a focus on sort of approach as well as some treatment options. And just to give a little background, mycosis fungoides is the most common subtype of CTCL that's characterized primarily by skin involvement with patches, plaques, or tumors, and less commonly any blood or lymph node involvement. And Sezary syndrome is more seen with more diffuse redness or what we call enflaking or erythroderma with some T cells in the blood with lymph node involvement possibly. So we sort of approach mycosis fungoides, particularly early stage mycosis fungoides, almost more as a chronic skin condition. And so sort of our treatment goals are to provide disease control, minimize sort of infections, particularly on the skin, and sort of improve, symptoms, including itching and quality of life. And so a lot of our treatment options really depend on the sort of the extent of how much the skin is involved, whether or not there is some involvement in the blood and symptoms of patients, and as well as sort of balancing the side effects of treatment. And this includes things, and for the majority of patients, includes some form of skin-directed therapy, regardless of what, whether it's sort of earlier or more advanced stage, but in select patients, localized radiation, and consideration of other oral or IV treatment options that sort of fall into this category of systemic therapies. And I just wanted to have a slide here that basically shows our typical staging that some of you have maybe seen as well. But basically what we're sort of focusing on is early stage mycosis fungoides, which for the most part presents in patients as sort of flat patches or you know, thicker plaques. So Dr. Horwitz, I didn't know if you wanted to add anything to that.
Yeah, no, I think the staging systems are can be complex, but I think we fundamentally think about, right, what kind of skin lesions you have and how much of your body is involved, and then is there significant disease inside the body, blood or lymph nodes or other, and not as opposed to insignificant disease, which we sometimes see. And I think that really we use that to inform sort of treatment strategies that are right for the individual.
Mm-hmm. So that sort of kind of leads to kind of our next point when we're seeing a patient that we are suspecting possible mycosis fungoides. Sort of the most important thing from a dermatology standpoint is really the skin exam, which sort of helps determine both the type of skin lesion, whether it's a patch or plaque, and I'll show some examples of what those look like. And then also sort of determining kind of the extent of the body surface area that's involved. And as you can see here, I have a photo that sort of shows how we calculate that, and using the patient's palm as sort of a representative, with 1% being sort of the total palmar surface of the hand, including the fingers. So here are some pictures of what we typically see with patch mycosis fungoides. And you can see here, these are kind of, in some of these, they look pretty sort of subtle, kind of flat, sometimes scaly or flaky, round or oval sort of patches. Typically, we see them in areas where we call them in almost like a bathing suit distribution, not so much in sun-exposed areas. And you can see, so areas like the thighs or the buttocks or kind of the lower trunk are common areas to see it. And you can see patients, you can see on the lower right, patients with darker skin types can sometimes present with sort of more kind of discoloration or what we call hyperpigmentation. And sometimes in patients of darker skin types and in children with mycosis fungoides, we will sometimes see more kind of light patches or hypopigmented patches. Sort of along the same lines, a plaque can kind of be in the same distribution and sort of the same shape, but they generally are thicker and have more sort of texture or surface change or substance to them. So they're in variation to, in contrast to a patch of mycosis fungoides. Tumors typically are kind of larger sort of nodules or you know, growths that are usually more raised on the surface of the skin, and sometimes they're usually seen in patients, they're sometimes seen in association with patients who have other patches or plaques, and sometimes there's some they can have some open areas of the skin with that. And then although the purpose of our discussion today is more on kind of early stage mycosis fungoides, I did want to just show what we're sort of talking about with the erythroderma, or kind of that diffuse redness and scaling that we see with in patients with Sezary syndrome. In addition to this kind of diffuse redness, we sometimes see some nail changes, some changes around like the eyelids and some hair loss as well. So go ahead.
Oh, no. So I was going to say, like, you know, I think maybe if we go to a picture of an early stage, one of the patches, you know, I think, right, one of the common scenarios where we'll see someone is there won't be a definite diagnosis. They'll be sent to us with either a suspicion based on how it looks, or maybe like these biopsy reports read in the right clinical context or cannot rule out mycosis fungoides. So when you see someone like that, when you see some of these, you know, maybe what we would call subtle, you know, less red, thin, you know, less number, you know, what are kind of the things as, you know, that you think about in approaching that person, in working that up?
So, you know, I think from like a history standpoint, I think some of the more important things are getting sort of a history of how the chronicity of this and how long this has been going on, and, you know, how the patient has responded to other treatments that have been tried. And it's not unusual for patients who have patches of mycosis fungoides to be diagnosed either just based on looking on the skin or even with biopsy as eczema or psoriasis, because sometimes with just patches on the skin, the findings can be subtle, both on the skin and on the biopsy itself. But I think sort of the biggest tool that we do have in patients who have patch or who you're suspecting patches of mycosis fungoides is to do a skin biopsy. And there are a few different ways to do a skin biopsy. Sort of the main two that we have sort of available in dermatology are to do a shave or a punch biopsy. And both of them can be useful in diagnosing mycosis fungoides skin lesions. And one of the things that can be challenging, particularly when patients have patches or plaques, and you can see here, is that it sometimes can look very similar to other scaly skin conditions like eczema or psoriasis, or even like superficial skin infections, like a fungal infection on the bottom. Sometimes kind of the district where these patches are can be helpful in diagnosis of mycosis fungoides, or maybe sort of teasing it from eczema and psoriasis, but typically a skin biopsy is sort of our main way to confirm. And a couple points that I want to make about a skin biopsy is, as the findings can be subtle, it's not unusual to require maybe multiple biopsies over multiple time points to really sort of make the diagnosis. And we usually recommend biopsying off of any sort of topical steroids. Topical steroids can be sort of anti-inflammatory, and they can sort of mask some of whatever the T cell process that's going on in the skin. So we usually recommend doing a biopsy off of any topical steroids to make the diagnosis. And sort of the last point that I think is important is that in patients who have maybe some areas that look a little bit flatter or patches and some areas that look a little bit thicker or plaques, it is helpful to maybe biopsy both of those because sometimes the process can be more prominent in kind of a thicker plaque area. And what our pathologists are really looking at on the biopsy are kind of the pattern of the immune cells in the skin, and that can sort of help point towards mycosis fungoides by looking at the cells or where they're sort of aggregating within the skin. And then there are some sort of ancillary studies looking for specific T cell markers that are seen more so associated with mycosis fungoides, and some sort of more molecular studies that identify a particular T cell clone or a specific T cell subset that sort of help kind of point more towards a diagnosis of mycosis fungoides.
So a couple of follow-up questions. One is, do you have a rule of thumb with how long you should be off steroids, topical steroids before a biopsy? And does it have to be all your spots, or can it just be some spots?
Yeah, so that's a great question. I think we usually say, I think in most, and a lot of this is based off of what we see with other skin conditions, which we use topical steroids for. And so usually I like to see patients off of it for, if possible, for 3 to 4 weeks. I think even in 2 weeks, we may see some of that sort of process returning, but I think to be sort of safe and baking, especially when you're dealing with kind of a flat patch where a biopsy finding might be a little bit subtle, waiting a little bit longer, about 3 or 4 weeks. In terms of whether to avoid topical steroids altogether, obviously this can be a very itchy and uncomfortable condition for patients. And so, I think if I'm seeing a patient first and then we see these patches, I think identifying even one area that would be a potential to not treat while treating all the rest. But if a patient's not bothered by it in terms of itching or discomfort, then I think it's a good idea even to just hold off on doing any topical steroids for at least 3 weeks.
And are there sometimes like that you just can't tell? You've done a biopsy, you've done another biopsy, and it's just not clear. And then what do you do, or what do you tell people? How do you manage that?
So, I think and you and I have shared some of these patients that have these biopsies that show some unusual immune cells, but they're really not meeting a definitive diagnosis for mycosis fungoides. And so I think there are kind of three possibilities. And one is that it's truly not mycosis fungoides at all. I think that's kind of on the lower possibility. I think the other two main possibilities are we're seeing something so early in its course that as we follow the patient, the biopsies and the skin findings may be more definitive if we were to biopsy later on. And then the third possibility, we do see these patients that fall into these categories where it's not definitive for mycosis fungoides, but they have a little bit of unusual immune cells. And there have been some associations of certain medications that may sometimes mimic these skin lymphomas. And so I will take sort of a good medication history and make sure there's nothing that they're maybe potentially were on prior to the rash starting. But oftentimes, the good news is that in the majority of patients, this is sort of a skin limited process, and we can sort of approach them similarly with sort of these mild skin treatments that we will talk about. And then follow closely, and obviously over time, if anything we're not responding, we always have we can always rebiopsy.
Thank you.
And so kind of along the same, we talked about the skin exam and the skin biopsy. Kind of a question more for you is in a patient that you see with patch or more early, what we would consider as early mycosis fungoides, what's sort of your approach in terms of other tests that you do, in terms of other blood work, or in which patients would you consider imaging?
Yeah, so I think about who we do more extensive workup or look for any evidence of lymphoma inside the body, right? So usually for us, that's people with more extensive skin lesions. So we talk about 1B as being more than 10% of your skin involved. Now there's a difference between 11% and 50%, but sort of the more that's involved, we would think about that. If we can feel abnormal lymph nodes, like if we feel swollen lymph nodes, that doesn't mean they're involved, but it means they might be, or if there's any abnormal blood counts. I think in a person who has a confirmed diagnosis, or we really think it's the diagnosis, who has, at least stage 1B, we usually at least look at the blood and then kind of individualize that for who we do scans on. I think like you're talking about, in the people who we're not sure if they have a diagnosis, like possible diagnosis, if we think it's either just a rash or mycosis fungoides and very limited, I try not to do a lot of these other staging tests, because sometimes you get information that's hard to interpret or confusing, can be a little scary. It can make us do more tests in someone who we don't even have a diagnosis and otherwise think it's unlikely that that there's lymphoma inside the body. In people who the differential diagnosis, like the choice is either mycosis fungoides or maybe another kind of T-cell lymphoma or another process like that, then sometimes we will do scans or blood work to rule that out. And then if we're not positive what's going on in the skin, well, we can say the worst thing it might be is skin-only mycosis fungoides, and that's a little more comfortable situation to just observe someone as opposed to not knowing what's going on inside. So those are kind of the parameters. I think it often comes down to an individual decision in talking with the patient, but I think those are kind of the issues that we think about.
Mm-hmm. Okay. So I guess kind of what we can sort of, unless you had any other comments, Steve, we can move on to start talking about kind of different treatment options that we would do in early stage mycosis fungoides. So in patients who we've sort of definitively made the diagnosis and who have, a lot of what I see sort of falls into this category where you have sort of a solitary sort of patch or kind of a slightly thicker plaque. And these are the patients where use of just a topical agent might be sufficient. And I'll talk about the three main topicals that we use, but there are also some others that have been reported in patients that might be helpful. But the main are topical steroids, topical nitrogen mustard, and topical bexarotene. in terms of our usual, typical treatment approach and kind of the main one that we start with is using a topical steroid. It sort of can have sort of multiple anti-inflammatory effects. And one of the things that I get asked from dermatologists and patients often is what type of topical steroid to use. And really, our recommendation is to use kind of a strong or what we call a high potency topical steroid twice daily. And there was a study looking at I think about 60 patients or 80 patients that were followed with using kind of a stronger steroid cream for about 9 months. And about 60% of those patients had sort of complete resolution, and sort of you can see in our photos here, which one of my colleagues shared with me. But about 30% will also have like some response in the skin lesion. The main thing is that when you stop using the topical steroid, it likely will usually recurs or returns in most patients. What we don't anticipate is that it's going to necessarily return in a different way or behave sort of differently, and we can sort of approach it similarly. But in terms of side effects, the main sort of side effects are kind of mild local side effects with kind of skin thinning and discoloration. But this is really something that we would see more after several months or longer of treatment.
Can I ask a question there? Because I hear
Sure.
a lot of times people say skin thinning. And when you say skin thinning, like what exactly does that mean?
So I think this picture hopefully sort of highlights it. You can kind of see basically like kind of right under the surface of the skin, there's a little bit of like thinning of that like collagen or that support structure, and what that sort of manifests as on the skin is kind of this fine, like almost wrinkling appearance, and that's sort of what we typically see. What patients are more familiar with are things like stretch marks, which we honestly don't see too much with the use of kind of topical steroids to limited patches, but more it's kind of this almost like fine wrinkling, kind of in fine, almost like indentation in the skin.
Is it ever dangerous, or it's just kind of looks?
So it's never dangerous. I mean, obviously it can be maybe bothersome to patients in the appearance. The one thing is that with stopping of the topical steroids, it is reversible, and we do see that the skin sort of improves. I think the way we sort of monitor how the skin is responding is more just like by looking at the skin. We don't usually sort of repeat skin biopsies unless there's something that seems like it's maybe not responding. But my usual approach is to use the topical steroid until the skin like redness or flaking sort of clears, and then I think most patients will need some form of plan where they're using it again when it either flares up, or even using it on the areas as maintenance, even when the skin is not active, maybe like once or twice a week. But I think that sort of discussion I have, once the skin clears. So I think the majority of our patients, this is sort of what we would start with. But in terms of, and then I just have a few things that kind of are things that may sort of improve the efficacy of topical steroids. We usually feel that an ointment is more effective and stronger than a cream. It tends to be a little bit more hydrating and occlusive, and I think that also plays a role. Where you're applying the topical steroid is also a consideration. So there are areas of the skin where the skin is already a little bit thinner, like the eyelids, whereas so that has sort of more increased steroid absorption than kind of where like the palms and soles where the skin is thicker, and so maybe the topical steroids don't penetrate as well. There are some things that we sometimes will recommend, and a lot of this comes from in patients who have things like eczema or psoriasis, on how to sort of improve topical steroid potency and efficacy. But particularly in areas where patients either have like maybe a thicker area or areas where the skin is thicker, like the hands or feet, applying the cream like under occlusion, where you either cover it with a Band-Aid or some form of a wrap, may sort of increase the absorption. And there's some thought that also applying the topical steroid when the skin's like after bathing or showering, when the skin is wet and more hydrated, can also increase absorption. So those are some things to potentially try if maybe just applying the topical steroid regularly, or in areas where we feel the skin might be too thick, to sort of increase the efficacy. So I think otherwise, in terms of other sort of topical agents, there's two other main ones that are FDA approved. My usual approach is in patients who have sort of a solitary patch, we do try topical steroids. However, if it's a slightly thicker patch, or they're not responding as well to the topical steroids, or they're previously tried topical steroids, then I think it's a reasonable time to sort of talk about these other treatments. Sort of the main one is topical nitrogen mustard, which was FDA approved in 2013. And the one that we have commercially available here is the 0.016% gel, or that goes by the name of Valchlor. And typically the recommendation is to apply it once daily. The main sort of side effects, and this is also why we sometimes may start with topical steroids and reserve this for patients that aren't responding, is that about almost 2/3 of patients will have some form of irritation as sort of a side effect with the use. And this includes sort of burning or itching or irritation. And this is sort of, minimized by treating with either topical steroids, either decreasing the frequency of the use, or even to maybe even prevent it, slowly titrating up the dose. And then there's been in the study that led to the approval of Valchlor, there was a small percentage, I think about 4% of patients that developed a skin cancer that wasn't a melanoma. It was sort of a skin cancer that we see as in patients who've had prior sun exposure, and so there's this question of whether using topical nitrogen mustard increases the risk of skin cancers. There's been long-term follow-up studies that haven't shown an increased risk, and I think some of this increased risk, it's a little hard to maybe fully interpret, because there are obviously patient personal risk factors like increased sun exposure, skin type, and use of other sort of medications that may increase the risk of skin cancer. And then kind of the last one I wanted to just mention, topical, is topical bexarotene, or a vitamin A derivative or retinoid. And similarly, it's FDA approved. In most patients, it does, just like nitrogen mustard, there can be sort of a long time before we start to see improvement. The main side effect is kind of similar to nitrogen mustard, irritation at the application site. And this is not unique to topical bexarotene alone. This is something that we see with use of topical retinoids in general, even when we're using topical retinoids for acne. And so usually there is sort of a mild skin irritation or dryness that is seen in the first few weeks of starting, but then sort of subsides. And so often, and I think even in the package insert for topical bexarotene, there is guidance on even starting every other day for the first week or so, and then sort of slowly increasing to twice daily. So those are kind of the three main sort of topicals that are used. I do want to just highlight a few other ones. But I do want to emphasize that these were sort of looked at in kind of small, like, patient series. And so I think the true sort of efficacy and utility of using these needs to be determined. But other topical retinoids, such as tazarotene, which is approved for use in psoriasis, has been shown to kind of work similarly to bexarotene. topical imiquimod, which some of you may be familiar with because it's used for treatment of warts and maybe other types of skin cancers. But it's kind of like a topical, like immune modulator, has also been shown to be like efficacious in kind of limited patches. Some of kind of the more recent what's been looked at in kind of solitary patches are things like photodynamic therapy, which sort of works along the lines of applying a topical kind of photosensitizing medication. So it's almost like a local PUVA type of effect, in the sense that the photosensitizing medication is taken up by the tumor cells, and then it's activated by a particular wavelength of light that kind of results in destruction of the area. And then similar to ultraviolet B or narrowband phototherapy, which we'll talk about as well, there is kind of a handheld device known as excimer laser, which is used, can be useful for using in solitary patches in areas where maybe the phototherapy wouldn't reach, like under the arms or in the groin. So these are some other things that could be considered in patients who may not have had a response to the topical steroids or some of the other topicals, or not able to get some of the other topicals, or having more side effects.
Sarah, is there a sort of a amount of skin involvement that you would or wouldn't use these things? Do you usually have people put these only on the spots where it's involved, or in broader areas, or any kind of decisions into how you pick one or how someone would use it?
So I think a lot of what we talk about and what we choose is kind of is really, I think, based on kind of the body surface area involved. I think I think topical steroids have the advantage of not having so much of some of the other kind of irritating side effects. So I think that sort of maybe limits use of sometimes my use of topical nitrogen mustard. I do think it's worth using in patients who have maybe a slightly thicker area, like one area that either hasn't responded to topical steroid, or we don't feel may respond as well to topical steroids. And so I think using topical nitrogen mustard there with sort of, that expectation that there will be some irritation. Whereas if someone has patches all over the body, or sometimes, and this is kind of a little bit more well-defined, but sometimes it's hard to kind of see where the patch starts and where it ends. And so I think that using something like nitrogen mustard or bexarotene that may cause a little more irritation may not be so sort of, preferable in those areas. So I think kind of that sort of helps determine that. And I think in patients who have a lot of patches, I think we're sort of then moving to more other skin-directed types of treatments. So I think that some of these would be less useful.
So if someone has really more extensive disease, what
Yeah,
would then be?
So I think more in patients who have, so oftentimes we see patients who kind of have mostly, like the majority of what I see is patients who have a lot of kind of these flat patches, and sometimes these slightly thicker like plaques, mixed in with that. And I think that those patients, I think it's certainly reasonable to have a topical steroid that can be used on certain areas or all areas, or ones that are particularly bothersome. But I think then a discussion of using something that's a little bit more what we call skin directed, and maybe kind of not just like a local treatment. And so our main sort of use of phototherapy is using a narrowband ultraviolet B phototherapy. PUVA is another thing that we, and I'll go through more because of sort of some of the side effects and tolerability. It's not sort of used as much anymore, but I am including it and the fact that there are some other oral agents and some other things that can be added if these skin-directed treatments are not sufficient. But I am just sort of including it for completeness. But in terms of ultraviolet B light therapy, it's thought to work in kind of multiple immune ways. It sort of suppresses the T cells in the skin. including their function and proliferation or growth, but also has effects kind of in stimulating the local like skin immune cells. So it's used widely in mycosis fungoides and then also in other common skin conditions. The advantage of that is that usually, and this is something we do at Sloan Kettering, is that we often are able to work closely with local dermatologists in the community because this treatment does require usually the patient to go to the photo unit 2 to 3 times a week, and each time you go, the dose is sort of slowly increased so that you're sort of tolerating the light therapy without any sort of burning or irritation. What we do know with the main sort of this form of phototherapy is that there's a good response in patients who have mostly patches, maybe a little bit less so in plaques. And that sort of makes sense because the ultraviolet B light sort of only gets more into the surface of the skin. And we have seen improvement in lighter skin types. That being said, as I mentioned earlier, in patients with darker skin types who get what we call more of these light patches or hypopigmented patches, this type of phototherapy can be quite effective as well. And it's overall pretty well tolerated. There's really no, side effects. Their patients may have a little bit of mild burning, like almost like a sunburn. And one of the things we talk about is on patients who are on other certain CTCL treatments, like an oral retinoid or a topical retinoid, that can sometimes make you more sensitive to the sun. And so it's not a reason that you can't receive phototherapy, but it's just something to sort of be aware about. And we sometimes will sort of start at a lower dosage and titrate up slowly. What we don't really know is when the skin clears, kind of what's the best sort of maintenance plan to do, or how. What we do know is that, once you stop phototherapy, likely the patches, will come back. We don't, again, similar with topical steroids, we don't anticipate that they will sort of be different in appearance or behavior. But there is some thought that maintenance therapy, which is really just going much less frequently, may potentially reduce this relapse or recurrence. And so that's something that I will, discuss with patients. And then, I think otherwise, in terms of side effects, really there haven't been anything that's shown. Sort of the other thing that comes up with patients is those who've had a prior skin cancer, whether it's safe to do phototherapy. And there really hasn't been much looked at with mycosis fungoides, but in long-term studies of patients who had psoriasis and were on phototherapy, there really was not an increased risk of skin cancers with this form of phototherapy. So it's something that I think is still fine to use in that setting. And then kind of lastly, PUVA, again, it involves the use of like an oral medication which sensitizes the skin to the radiation. UVA tends to kind of penetrate a little bit deeper in the skin, but there are some more side effects associated with it, including some sort of more immediate side effects, but then also things like sun damage, increased risk of skin cancers. And so I think it's something that is still can be considered in patients who maybe have sort of kind of thicker skin lesions, but sort of with the advent of some of our other treatments, I think that this is a little bit kind of lower on what we use. So I did want to ask, so, we kind of talked about mostly what we see with patients who have just like a single patch or kind of mostly like patches with maybe a few kind of what we call plaques. I guess if a patient sort of comes in with mostly plaques, still, we would early stage MF, I wanted to ask Dr. Horowitz what his sort of, approach to this patient would be. Would this be, and what sort of treatments you would think about?
Yeah, I think we often will see things like this for people. It takes them a while to be diagnosed, or the disease is more extensive and they're really uncomfortable. And I kind of think about the CTCL treatments in kind of like sort of two ways. Like, right, there's treatments that relieve symptoms, help you feel better and look better by treating the skin. Those often, like you said, like maintenance therapy for light, are given on a long time. Um, um, and then there's treatments that might like keep you safe, like if the disease is really growing really quickly. So, I think when we see people with more extensive skin disease, sometimes they're really uncomfortable, and the mildest treatments that can be given and used for a long time tend to be a little slower acting, right? Sometimes steroids work quickly, but sometimes it can take weeks or some months. Sometimes with thicker lesions, they don't get people completely better. I think historically, one of the most effective or the most effective treatment we had for the skin is radiation. But the way it used to typically be given when we give radiation to the whole skin, or something called total skin electrons, was it would be a pretty like hefty dose of radiation, something that we use to treat systemic lymphomas. It would almost always clear the skin, but there would be hair loss, there could be temporary loss of nails, there could be more side effects, and you couldn't give it over and over again. So we kind of used to save that, for when things like really got bad and we had to kind of reset and bring everything better. Our radiation oncologists and some at other centers around the country have been really looking at more and more what we call low dose or very low dose, or sometimes these very low doses of just a few treatments of radiation. So we are seeing that there are some people who, with a very low dose of radiation, their skin gets a lot better and they don't get all those long-term side effects, and we still have room to go back to it again and again if we need it. So there will be very select times, where someone's so uncomfortable, we'll use that treatment to try to get things better quickly. So I think that's a newer thing that we're still learning about, but we're doing a little bit more and more. There are occasional times we would start with a systemic therapy. Most of our safer systemic therapies do take a while to work, so they may take weeks to a few months to work, but there are occasional times where some of the stronger systemic therapies, things either chemo or not exactly like chemo, that we would give in someone with disease only in the skin, but most often, because those treatments have a high risk of side effects, we kind of reserve them for people who really have a lot of disease outside the skin, or disease in the skin is really not getting better with skin-directed therapies, because the skin-directed therapies are still sort of the safest ones we have.
Mm-hmm. And then sort of, I guess, sometimes we see these patients with what we call early stage MF, and you may check your, the sort of the blood test, and you may see some, small amount of T cells in the blood. Does that sort of change your approach, or how does that sort of?
Yeah, I mean, sometimes there's a very small amount, and sometimes we look and it's sort of a trivial amount. And in that case, if there's a teeny tiny little bit, we sort of have these tests where people used to look at blood smears on a slide and count abnormal cells. And now we have, fancy machines, things called flow cytometry, they can find 1 in 10,000 cells, or there's even some genetic tests that can find even less frequent cells. So I think when it's super teeny tiny, it may not really affect our therapy. It may just be something we follow. If there really is disease outside the skin, like of a reasonable amount, or disease outside the skin and the skin treatments aren't working as well as we'd like, then we sometimes, sorry, I got asked to vote on feedback. I'm not even done talking. Wait, I got the best is yet to come. No, sometimes we will start mild systemic therapies, like the retinoids are something we'll commonly give in combination with light. There's low doses of a very low dose of an oral chemotherapy called methotrexate. Sometimes those very mild systemic treatments we might add in as what we call an adjuvant, or in addition to the skin-directed therapy, either to prevent progression, in the blood, or maybe to boost the skin treatment a little bit.
Mm-hmm. Great. So I think we can open it up, I guess, to questions. I just really just had one more slide just saying that, kind of making sure we're doing good sort of supportive skincare is always, and in all stages of mycosis fungoides. We address, it can be very itchy, and that can have an impact on quality of life. So using agents to kind of help with the itching, and then decreasing risk of skin infections is another aspect of our approach.
Great, thank you. And I'm sorry, I clicked the wrong button there with the poll. I didn't mean to launch that so soon.
Everyone's up and ready to vote these days. So
Yes.
it's right, we're all primed to.
Thank you both so much. We've already had a couple of people just letting us know that your presentation was really well received and easy to understand, and great slides. So thank you both so much. This has been really helpful and informative, and we won't be able to get to all the questions tonight, but we will do what we can. So I will stop talking here and ask the first question. When would you use a genetic screen to predict T-cell lymphoma aggression?
Yeah, I can try that. I don't know that we have a real strict genetic screen to predict aggression. We have genetic tools to look for very small amounts of disease or to try to clarify diagnosis. And unless I'm missing something, I don't know, Sarah, you can tell me, we have genetic screens to sort of characterize some of the abnormalities inside the tumor cells. I think some of those correlate a little more with faster growing disease, but they don't define it. So some of that helps us figure out targeted therapies, or some of its research and may help us understand the biology a little bit, but I don't think there's a specific gene that tells you it's more aggressive if you're not seeing it behave more aggressively in the person. So it might be something that we worry a little bit about, but we would still watch and see what happens in the person before pulling the trigger necessarily on stronger therapies. Hopefully I'm catching the meaning of that question.
Let's see, assuming only skin involvement, how do you determine remission has been achieved?
So yeah, that's a good question. I think our typical is by our exam is how we determine clinical remission. And so, we look for kind of most patients will have patches that are red and scaly. So we look for those signs to be gone. We don't typically do like a repeat skin biopsy in an area where there was a prior patch. But usually it's more by sort of our clinical exam. And that sort of determines that. And also one of the other things is we see an improvement also in symptoms, like improvement in itching and that sort of thing.
Okay.
And I think I would just add to that, I think when we're treating with skin-directed therapies or creams, the idea is that this may come back, but we're intentionally using mild and safe therapies so we don't put the person at any risk in the short term. Historically, giving stronger treatments early on has not helped down the road. It may clear the skin faster, but there's a cost in terms of long-term side effects, so we don't do that. We're sort of hopeful, though this is experimental, that some of the new immune therapies may change that. There may be treatments that work a long time, but right now, if you're being treated with a cream, the goal is to get things better, not necessarily get rid of every cell forever, because we don't really achieve that.
Mm-hmm. Okay. How is erythrodermic MF/Sezary determined, especially related to the eyelids? I'm not quite certain. Do you want to take this one, Dr. Noor?
So I guess there was like two parts to it. I think the first part was
the first part. How is erythrodermic MF or Sezary determined?
So it's sort of partly clinical in terms of we define usually partly the main thing is looking in the blood for the T cells in the blood sort of meeting a certain criteria and number, and so that's how a diagnosis of Sezary syndrome is made. In conjunction with that, patients will typically have sort of what we call erythroderma, or that diffuse redness and scaling that we see. We have had some patients, Dr. Horwitz and I, that have sort of kind of milder skin presentations and have sort of more what we would define as Sezary level in the blood. But the majority of patients will have sort of this diffuse redness and scaling. Sometimes when you have that like around the eyelids, it can lead to kind of changes around the eyelids where you see like the skin, sometimes it can be inflamed, and so the eyelids can become puffy, or it can sort of pull at the, you can see sort of like a pulling out of the eyelid. So that in itself is not something that we see just by itself in Sezary syndrome, but it sometimes can be seen in the whole picture.
Okay, thank you. Let's see, diagnosed via biopsy of a lone tumor, no other symptoms, treated with topical steroids. And then the question is, should I anticipate development of other skin lesions and plaques?
Probably, there are people that truly have what we call single sites or unilesional, or there's some names associated with that. And if you have a single spot and it really goes away, very, very occasionally people don't get another spot. Most people get recurrent spots. They're not likely to be dangerous. They're not likely to be a higher stage, but most people will get another spot in the skin at some point in their life.
And I think kind of the other thing is just having sort of close follow-up with your dermatologist and oncologist, and with, if a new spot were to emerge, to have that biopsied as well to sort of see if it's the same process.
Mm-hmm. Great. Diagnosed with MF stage 1A. I had UVB therapy for 6 months. The patches disappeared. What are the chances of them reappearing? If one is 1A, do we know what % of patients progress to more involvement?
Go ahead. No.
I think our best data is that people who start with 1A tend to get recurrent spots. So again, that's most likely, but usually don't go to a higher stage. Probably 5 to 15% of people who start at 1A, and that's from some data we have, would go to 1B or higher. So 85 to 95% might stay at 1A. So it's likely that it would stay like that. But again, you would be followed. And if it was increasing in skin surface area, that's not necessarily dangerous, but there are treatments, and maybe the choice of treatments might change a little if it did involve more skin.
Just to compliment to you both, great slides and photos, easy to understand. And they noted the armpit looks exactly like mine. Back there. I'm sure it's nice to, see somebody that looks similar to yours. So thanks for the feedback. Are topical and other treatment options for LYP the same as for MF?
Yeah, so, so LYP, for those who don't know, it's more of kind of a chronic, almost like waxing and waning, these bumps that sort of come and go. And, I think we do use like things like topical steroids more to kind of help with like symptoms associated with LYP. There is a possibility that it may shorten the course of LYP. But, I think we generally don't use the other sort of topicals, and more kind of our focus is more like if we are using a topical steroid, it's more to help with symptoms.
Okay, and actually similar to that, so for topical steroids, does it matter if it is applied once or twice a day? If the patch is showing good results, is once a day enough?
So that's a great question. I think, in terms of the efficacy, there's probably not a lot of difference, or there really isn't probably a lot of difference between once or twice a day. And so I think once daily application is sufficient.
Okay. Is there a need for treatment at all if the rashes, plaques, or tumors are not bothering the patient other than being unsightly?
Yes, this is a good question. We don't know. So I think when we talk about these really low rates of going to a higher stage, and again, tumor is a little different. Tumor to us doesn't means a specific lump, and we kind of stayed away from that on this topic. But for patches and plaques, our data that things don't frequently go to a higher stage are usually from centers where there's been a bias towards treatment. So I think that keeping it minimal on the skin, as long as that treatment is safe, may give the lowest chance that it would get worse or progress to a higher stage, but we don't really know that. And we definitely see people who are diagnosed and they say, I've had that spot for 15 years and it never got worse. So my guess is statistically overall, it may help things stay better and may reduce the chance that they get worse. But in any individual person, it may be more making you look better and feel better, but not, helping you have a good future, which you may have already in spite of it.
Someone just said, what about triamcinolone 0.01%?
So triamcinolone it's what we would consider kind of a middle strength topical steroid. I think the advantage of that is that it usually, of all the topical steroids, it comes in kind of a larger amount. And so, I think for patients who have many patches, it's kind of a good option in terms of the amount that you can apply. I think we do know that stronger steroids are probably a little bit more efficacious, but I think that you may likely will still have a good response to topical triamcinolone. There may be slightly of a longer response, but I think it's still, I think for reasons of it coming in kind of a larger amount and being able to use it on a larger body surface area, it's still a good option.
This one has a little bit of a backstory here. Maintenance UVB therapy overview is so helpful for me after completing an intensive course of lightbox. I have done nbUVB every other week for almost a year. One relapse forced me into the lightbox 3 times a week for a month, now back to every other week. This has been a superior plan to previous completion of therapy and then a big relapse requiring months of lightbox 3 times a week. Am I at risk, an increased risk of other skin cancers?
So, as I mentioned earlier, there hasn't, in terms of their patients who've been on, have other skin conditions that have received light therapy, there was no sort of real increased risk of any development of any skin cancer. So I think, I think for patients who kind of have a quick recurrence of the skin patches after stopping the light treatment, I think a maintenance plan is reasonable, and going, once every few weeks, or once a week or once a month, depending on what's sort of needed, I think is a good plan.
Okay. This one, I would like your thoughts on a wait and see approach. And then they added stage 1B MF, hypopigmented patches and small red, slightly raised patches, no itching. nbUVB, not well tolerated, experienced burning and stopped and started twice, but ultimately maxed out at 520 mJ, diagnosed CD8 plus MF in February 2019, and then last UVB treatment was December 2019. So thoughts on wait and see what happens.
Yeah. I think that makes sense. Some of these, most CD4 and CD8 are kind of markers on the tumor cells or the lymphoma cells. Most mycosis fungoides is CD4, which is one kind of T cell, some is CD8. There are people with hypopigmented patches and CD8 that have a very sort of what we call indolent course. It's kind of persistent, it doesn't grow. We sometimes see that presentation in children, and they do very well. So I think light narrowband UVB would be a good choice. If that wasn't tolerated, I certainly would watch before escalating to more intensive therapies or therapies that have more risk of side effect. And if it got worse, you could always add therapy. So I think in that specific case where light wasn't tolerated, it makes sense. I don't know, Sarah, do you have?
No, I agree with you. I think the other thing is, there are many different ways to sort of start, like what dose to start. There's variability in what dose to start light therapy with, and how to increase it. And so I think, and especially with patients who have lighter patches on the skin, I think we go even a little bit slower in increasing the dose. So I do think it doesn't necessarily mean that light therapy isn't a great option. It's certainly possible that maybe you won't tolerate it, but I think there is room to experiment a little bit with how it's maybe given to sort of minimize that.
Okay. And because of time, we just have time for one more question here. What should I look for in blood results in early stage?
Probably nothing. It's probably normal, and you probably won't see any. So I would try not to do too many blood tests too often, but it's probably just normal blood work. Since that was such a short one, do you want to do one more?
Sure. What is the max dose of nbUVB?
So that's a good question. There's not like a discrete maximum dose. I think it's a lot of it's based on the skin type, and it's also based on how you're tolerating the light therapy, and how you don't necessarily need to get to the highest dose for all patients. If your skin responds and clears at a lower dose, our preference is to sort of keep that lower dose. And so I wouldn't say that there are some guidelines that we have where we may not necessarily go up higher than a certain dose, and that's based on maybe each photo therapy unit, but we don't necessarily need to go to the highest dose for every patient if your skin is responding well to a lower dose.
Okay, great. And we also had a quick shout out from Michael Young from the board of directors, and he just wanted to thank you both on behalf of our board. And he just had sort of mentioned that while more advanced patients may need more medical care, the majority of our patients are in early stage, and this information is invaluable. So thanks for the shout out, Michael.
Thanks, Michael.
And
Thank
I'm going to
you.
go ahead and just launch a quick poll here for everybody. If you would please go ahead and give us your thoughts on tonight. We really do take your feedback seriously. We appreciate all of it. And thank you so much, Dr. Horowitz and Dr. Noor. We're so appreciative of your time tonight, and it was just invaluable to be able to provide this for folks this evening. So thank you both. And thank you to everybody for tuning in. We hope that you learned something new tonight and came here for the information that you came for. And we hope to see you at a future program. We do have our next Facebook Live event will be November 19th, and that's at 6 o'clock Eastern Time. And we will actually be having 2 of our board members join us for a little bit of a board foundation update then. So we hope that you can join us, and we hope to see you at a future event. So thank you both. Have a great evening, and thank you so much, everybody, for joining us.